about you, girl, and I don't think it's just your smile. I don't know how to say it now. I've been thinking for a while. The best way to say it, woman, your energy is right, yeah. Before I hold you in my arms, I wanna hold you in my heart. Before we share our love up on that bed, I wanna place this crown up on your head, woman. Girl, you're my queen, majesty. You are my queen, majesty. Don't you know you are my queen, majesty? Oh, you are my queen, majesty. Queen of the jungle, you are the lioness. Other feline a grumble, but they're always trying your best. So when the whole world a crumble, your lion is alright. Before I hold you close, just before I hold you close, oh girl, I wanna let you know that when all is done and all is said, you deserve that crown upon your head, woman. I said, queen, don't you know you are my queen, baby? Majesty, yes, you know you are, majesty. You are my queen, baby, majesty. You know? So hear me now. Well, me say Cleopatra, Queen of Sheba, Nefertiti, are you are your feature? Empress, man in a beautiful creature. You summarize every queen of the east seas out. Every night crawler and gully creeper. I'm in a no.
Well, hello and welcome everyone. We are so excited to see you. I'm loving all the feedback in the chat. We're excited that you're joining us today at our January Collaboratory. To start off, I'd like to introduce our interpreters. We have ASL and Spanish interpreting available today, and you will see our ASL interpreters on the screen. So I want to give it to Yaya and Angie to start off with a language introduction.
Hola a todos, bienvenidos. Primero quiero presentar a los intérpretes de hoy. Mi nombre es Yaya y estoy junto a mi co-intérprete Angie, que vamos a ser sus intérpretes del español a inglés. Y también con nosotros está OD y Jemaya haciendo interpretación lenguaje de señas norteamericana.
Hi everyone, I'm Yaya. Wanted to introduce myself and my interpreting partners, which are Angie, OT, and Jemaya doing ASL.
Estamos hoy aquí para interpretar entre inglés y español, trabajando con un marco que se llama la justicia del lenguaje.
We're here today to interpret between English and Spanish within the framework called language justice.
La justicia del lenguaje incluye el compromiso de la presencia plena de todos y la capacidad de comunicarnos en nuestros idiomas. Reconocemos todos los idiomas presentes hoy aquí y en particular los idiomas de los pueblos indígenas de esta tierra. Yo estoy en tierra no cedida Tatavium, en lo que se conoce como Tujunga, California, y Angie está en Tobangar, en el basin de Los Ángeles.
Language justice includes a commitment to everyone's full presence and capacity to communicate in our languages. We acknowledge all the languages here today, and especially the languages of the indigenous people of this land. I'm on unceded Tohono, O'odham, and Yaqui territories, and Angie is in Tongva territory, where both communities continue in resistance.
Estamos utilizando la función de interpretación de Zoom, que será activada en unos momentos.
We'll be using the Zoom interpreting.
Si usted está conectando con su computadora, usted va a ver un icono en la parte inferior de su pantalla.
If you're joining from a computer, you will see a globe icon on the bottom of your screen.
Si está conectando con su tableta o teléfono, cuando se active la interpretación, va a pulsar en más y verá un menú que incluye la opción de interpretación de idiomas.
If you're joining from a tablet or phone, click on More, and you will see a menu that will include an option called Language Interpretation.
Para poder escuchar la interpretación, va a pulsar el icono de mundo o interpretación de idiomas. A continuación, elija su canal de idioma. Si está usando una tableta o teléfono, asegúrese de hacer clic después de escoger su idioma y en finalizar después de escoger su idioma.
To listen to the interpreting, click the globe icon or language interpretation. Then choose your language channel. If you are using a tablet or phone, make sure to
Can you hear me?
yes, sí.
Sorry, there was a little mishap. Selena, I'll let you know at the end of the introduction that you can then set up the interpretation, because if not, no one can hear us. Selena, te voy a dejar saber cuándo podemos comenzar, porque si ponemos, empezamos la interpretación, nadie nos puede escuchar.
Okay. I'll just repeat myself. Me voy a repetir. To listen to the interpreting, click the globe icon or language interpretation. Then you will choose your language channel. If you're using a tablet or phone, make sure you click on Done just once you chose your language.
Si no puede escuchar al intérprete, por favor no sufra en silencio, use la caja de chat o contacte a Selena para recibir ayuda.
If you can't hear the interpreter at any time, please don't suffer in silence. Use the chat or contact James for help.
Las personas que entienden español habrán notado que usamos la terminación E en vez de la terminación A u O, por ejemplo, cuando dijimos bienvenidos al inicio. Esto no es un error de pronunciación, sino un esfuerzo intencional de crear espacios inclusivos y evitar hacer asunciones con relación al género, porque la justicia del lenguaje es también justicia del género.
Folks who understand Spanish will have noticed that we use the E ending instead of the traditional A or O ending. For example, when we say something like bienvenidos or welcome when we begin. This is not a pronunciation error, but an intentional effort to create inclusive spaces and avoid making any assumptions about gender. Language justice is gender justice.
Gracias, por último, gracias a Iniciativa de Partos Prematuros de Los Ángeles por hacer posible que estemos aquí. Nos da mucho gusto poder apoyar este espacio multilingüe, ya que sentimos una fuerte solidaridad con el trabajo que hacen. Y ya con esto terminado, se puede activar la interpretación. De vuelta a ti, Celina. Gracias por su atención.
Last but not least, thank you to LA Preterm Labor Initiative for making it possible for us to be here. We are so pleased to be able to support this multilingual space, since we feel strong solidarity with the work you do. Thank you, and back to Selena. Interpretation can be activated now.
Fantastic. Thank you both so much. Well, I just want to welcome everyone to this collaboratory again. Our collaboratory today is entitled Supporting COVID Positive, Pregnant, and Parenting People, Community Perspectives, Challenges, and Solutions. I want to share our organizational highlight, which is the Roots of Labor Birth Collective. The Roots of Labor Birth Collective is based in Oakland, and they support BIPOC at every stage of reproductive life. Every Monday since 2015 to 2020, shelter in place. Doulas have been making in-person prenatal and postpartum visits to the Santa Rita jail. They supported labor, birth, immediate postpartum for those who deliver in custody and who would otherwise not have outside support. So we are fundraising to support reinstating the Santa Rita jail doula support. And so we ask, if you enjoy this session, you can donate at the red text on the screen, and it will also be in the chat. You can learn more at their website, which will be in the chat. And we appreciate you all for learning about this important issue. So let's move on to our speakers. We have an incredible lineup today. To start the session off, Dr. Brittany Chambers and Helen Arega are going to share a presentation on the Priority Voice study and how COVID-19 has affected pregnancy and birthing people. Next, Dr. Nikitra Burse and Deborah Dowda will moderate a panel discussion with our amazing panelists that you see here: Joanne Allen, Julia Marinas, Tamara Gardner, Renetta West, and Kaya Shatim. We'll end with questions from the audience. So if you have questions, please put them in the Q&A section on the Zoom section, or we will be looking for raised hands so we can allow you to ask your question live. We will be holding questions till the very end though. So in the meantime, communicate through chat if you need. So I'm going to hand it over to Dr. Brittany Chambers and Helen Arrega. Please give them a warm welcome.
Good morning, good afternoon, wherever you are at. We are so excited to be here at this place, and just want to just thank everyone, extend gratitude for everyone showing up, right? We are in a pandemic, which seems never ending. And we're excited to be sharing data collected from birthing people who contracted the coronavirus or COVID-19 at the height of the pandemic, that we were able to follow them across their pregnancies, to learn from them about challenges and solutions to improve maternity care, and particularly uplifting the voices of Black, Indigenous, and people of color or BIPOC people. Next slide, please.
There are alarming racial inequities in pregnancy and birth outcomes that persist. Black birthing people are 3 to 4 times more likely to experience complications during childbirth and die from those complications compared to white birthing people. There have been similar inequities seen in COVID-19 exposure and deaths among BIPOC communities. These inequities highlight long-standing, deeply rooted racist policies and practices alongside a lack of robust, well-funded social services to dismantle them. The COVID-19 pandemic has critically impacted and changed how we operate and receive healthcare services, especially among maternal healthcare provision. Changes to maternity care delivery during the pandemic has had significant implications for birthing people and their families, exacerbating inequities. Next slide.
So in response to this, the Pregnancy Coronavirus Outcomes Registry, or the Priority Study, was one of the first national pregnancy registries launched to understand how COVID-19 impacts pregnant or recently pregnant people and their newborns who are either under investigation for COVID-19 or have been confirmed to have COVID-19. The Priority Study was launched in March 2020 by Dr. Yalda Asher, Dr. Valerie Featherman, Dr. Stephanie Ga, and Dr. Vanessa Jacoby. Next slide, please. A few months after, my colleagues and I were approached to create the Reproductive Health Equity and Birth Justice Core, or the RHE and BJ Core, for the Priority Study. The overall goal of the RHE and BJ Core is to provide a platform within the Priority Study for authentic and transparent community engagement within BIPOC and queer communities. The RHE and BJ Core is housed in CERISH, which stands for Community Engagement Research Incubator and Strategy Hub. CERISH was launched in collaboration among 7 Black women, including Dr. Afenwa Asuadu, myself, Dr. Andrea Jackson, Dr. Kia Shrine-Jeffers, Dr. Monica McLemore, Dr. Karen Scott, and Judy Young. CERISH would not be able to function without the support provided by Hendrix, Gabriella, and Kia. So thank you all for supporting us in the work that we do. Next slide, please. One of the first objectives of the RHE and BJ Core was to develop a national community advisory council. Pictured here are all 20 members of the Community Accountability Council, or our CAC, representing Illinois, DC, Mississippi, Alabama, West Virginia, Texas, New Mexico, Florida, New York, Georgia, and South Carolina. Next slide, please.
All right. The Priority Pregnancy Coronavirus Outcomes Registry, Voice, Visioning Opportunities to Improve Healthcare and Equity study was launched to qualitatively explore the perceptions and experiences of engaging maternity care during the COVID-19 pandemic among pregnant birthing people with COVID-19, and to identify barriers and solutions to engaging in maternity care and possible solutions on how to improve prenatal and birthing care experiences. We would like to acknowledge our funder, the California Healthcare Foundation. Thank you so much for supporting this work, very important work, and thank you so much for supporting us. Next slide, please. Now to introduce our fabulous team. The wonderful Dr. Brittany Chambers is the principal investigator for the Priority Voice study. Myself as the program manager. We have two brilliant graduate student researchers, Ariel Bell and Tamara Nelson, who collected and coded qualitative data, and two amazing RHE and BJ core CAC members, Deborah Dauda and Dr. Nikitra Burse, who played a very important role with reviewing interview guides, drafting the manuscript, and supporting the Collaboratory today. Next slide.
A purposeful sample of pregnant people who were COVID positive were recruited from the Priority study. We developed two semi-structured interview guides, one for pregnancy and one for the postpartum period, in partnership with the RHE and BJ Core CAC, as well as other investigators. We conducted interviews during two time periods. The first was at 28 to 32 weeks gestation, and interviews were conducted between July and October of 2020. And the second was during 6 to 12 weeks after birth. And these interviews were conducted during October 2020 through February 2021. Participants were remunerated $40 for participating in each interview. All of our interviews were audio recorded, transcribed, and coded using deduce. And we used thematic analysis to identify emergent themes. Next slide, please.
All right, now to get a little bit into the demographics. We interviewed 35 birthing people during their pregnancy and early postpartum periods. The mean age among women included in this study was 30 years old. We had a diverse study population with about 75% identifying as Black or African American, Native American or Alaskan Native, Latinx or Hispanic. The majority of participants reported being married, living with a domestic partner, or living as married. The majority of our participants, almost half of our participants reported having an advanced degree and were currently residing in the southern part of the United States. Next slide, please.
Now we are going to briefly highlight some data from the study, first starting with individual level. So individual level factors were defined as issues birthing people experienced personally as a result of being COVID positive and changes to day-to-day living during the pandemic. Birthing people identified three primary factors. The first was having COVID-19, and the impacts of the COVID-19 pandemic produced many stressors for birthing people. Birthing people expressed experiencing challenges with employment when they discussed their COVID-19 status with their employer. Second, the pandemic brought on many stressful challenges that caused birthing people to struggle mentally and emotionally. Many birthing people shared that their responsibilities, specifically those who have young children at home, increased during the pandemic, making them feel like the workday never ends. The last factor was birthing people expressed that they experienced similar inaccessibility to resources, particularly pertaining to postpartum depression once giving birth to their baby. Individual level solutions are defined as things that can help improve the challenges birthing people experience personally as a result of being COVID positive and changes to day-to-day living during the pandemic. 2 solutions were identified. Birthing people stressed the importance of income supplements, such as the stimulus, to support people and families during the pandemic. They also shared mental health was a reoccurring issue experienced by birthing people during pregnancy that heightened during the postpartum period. Birthing people expressed a need for more mental health support to help unpack pregnancy, parenthood, the pandemic, and more. Next slide, please. So moving into the interpersonal level factors, we defined this as interactions with providers and staff navigating maternity care, both remotely and in person. Birthing people identified 3 personal factors. The first was birthing people, specifically those of color, described receiving more attentive care from their providers due to their COVID-19 status. They expressed that their providers were interested in learning more about how they felt and shared affirming statements encouraging them to remain positive about their COVID-19 status. Despite the increase in visibility being COVID positive brought to people of color, all birthing people in the study expressed experiencing discriminatory care due to their COVID-19 status. Lastly, birthing people shared that their providers had limited information about COVID-19 and how it may impact their pregnancies. The lack of information about COVID-19 in pregnancy caused birthing people to worry about their capacity to carry their pregnancy to term, vertical transmission of the virus, and caring for their newborns. Interpersonal solutions are defined as recommendations to improve these interactions between birthing people, providers, and staff navigating maternity care, focused both on remote as well as in person. And 2 solutions were identified. Birthing people expressed understanding that COVID-19 is novel and information about how it impacts pregnancy and infant health is an ongoing discovery. However, birthing people noted that the information available about how COVID-19 will impact maternity care and engagement is necessary. And lastly, birthing people expressed experiencing discriminatory care due to their COVID-19 status. They felt like the quality of care received by providers and staff was ingenuine and recommended training on humility directly related to caring for COVID positive patients. Next slide, please.
Thank you. And now lastly, we'll move into institutional level factors. Institutional level factors are defined as clinical and hospital level factors that influence the care offered to birthing people during pregnancy and postpartum periods. Birthing people identified 4 institutional factors. 1, birthing people shared moving from in-person only appointments towards telehealth only or blended combination of in-person and telehealth caused a disruption in their care access and engagement. Birthing people shared having to see multiple providers and staff personnel across their pregnancies made them feel like they were unable to connect. 2, birthing people repeatedly emphasized that there were several constraints with obtaining the support and information they needed during telehealth appointments, such as vitals. Birthing people specifically discussed how telehealth appointments substantially reduced their providers' ability to accurately assess for and manage any health risks. 3, birthing people further shared the limited information provided during pregnancy impacted their accessibility to resources, such as infant feeding options and lactation support in the postpartum period. And lastly, birthing people consistently described frustration with the restriction of support persons attending appointments during their birth or during pregnancy. And then furthermore, they've shared that this restriction made it challenging for their partners to really connect with their pregnancy. Now we'll move into solutions. Institutional solutions are strategies to address clinical and hospital level factors that influence the care offered to birthing people during the pregnancy and the postpartum periods. Birthing people described 3 solutions to address challenges they experienced. 1, birthing people expressed the need to have access to tools and resources to properly engage in virtual maternity care. Many birthing people had plans to breastfeed and experienced challenges in initiating and sustaining an infant feeding plan centered around human milk. Birthing people expressed breastfeeding challenges improved once they were linked to a lactation consultant. And lastly, birthing people stress the importance of being able to have a support person or persons attend prenatal care visits and births in the hospital settings. As we followed birthing people across their pregnancies into their postpartum period, we can see that this recommendation was implemented by the time participants gave birth, with the number of support persons allowed in the birthing room varying across geographies. Thank you so much for listening to our presentation. We'll now flow into our panel discussion. We collected this data at the height of the COVID-19 pandemic. All birthing people in our study were pregnant and seeking care and birthed their babies in 2020. We know lots has changed with the pandemic and maternity care since then. I will now pass it off to our lovely moderators, Dr. Nikitra and Deborah, to start off our panel discussion to hear community perspectives from people who have been on the ground serving birthing people during the pandemic. Take it away, ladies.
Well, good afternoon, everyone. I am Dr. Nikitra Burse, and I'm from Mississippi. So you could probably hear my southern twang in my voice. So I'll definitely make sure that I'm speaking clearly for everyone. But I'm based in Mississippi. I own a public health research development and practice company where most of our work is around Black maternal morbidity and mortality. One of our major projects is that we have produced a documentary featuring many people close to me around Black maternal morbidity and mortality. And Deborah, I'll pass it over to you.
Thank you so much, Nikitra. I'm so excited to be here with y'all today. My name is Deborah Dauda. I am part of this wonderful CAC village that you've been hearing about. I am a mother of 2. I'm an activist, a dancer, an educator, and a third-year PhD student in the School for Global Inclusion and Social Development at University of Massachusetts, Boston. My work is dedicated to the flourishing of Black women and girls wherever they are. I trace my matrilineal lineage to the village of Oga in Nigeria in Kogi State through my grandmother, Febe Dada, and my mother, Abosede Koporola Dada. So I'm here today because of them, and I give thanks, and I look forward to engaging with y'all and hearing about your perspectives.
Thank you, Deborah. So we will start with some introductions from our panelists today. And as our panelists come up, we're just going to ask them to just share their name, organization, and the community that they serve. Also, as you come up, panelists, please remember that we do have interpreters on, and just make sure that we speak clearly and slowly. Thank you. So we can start, let's see, Tamara. I'm just trying to go by who's on my screen.
Hi, my name's Tamara Gardner. I use she, her pronouns. I've lived in Albuquerque, New Mexico for the last 15 years. It's important for me to start by acknowledging that this is the land of Pueblo, Navajo, and the Apache, and that Albuquerque sits on the traditional homelands of the Pueblo of Sandia. I've been a nurse midwife at the University of New Mexico Hospital for 10 years. And then recently I returned to school, and I am now also a psychiatric nurse practitioner. So I'm going to be expanding my practice to include perinatal psychiatry as well. In 2018, I co-created a volunteer doula program at the University of New Mexico Hospital. It's called the Birth Companion Program. And it's a birth justice focused program that aims to provide respectful, compassionate, and non-judgmental care to people who may not otherwise be able to access continuous labor support.
Mhm.
Our program acknowledges the diversity of people and their reproductive choices and hopes to improve birth experiences and lessen health disparities in pregnancy care. Thank you.
Thank you, Tamara. We're excited to welcome you on.
Thank you.
Kayayo.
Good morning, everyone. My name is Kayayo Shettin. My pronouns are they, them, she, her, and I am blessed to reside on unceded Lishan territory. I am currently a full spectrum doula and an apprentice home birth midwife. So I'm studying to become a home birth midwife. And if you know anything about midwifery, there are not a lot of Black home birth midwives. So I'm on the path to join my mentors. And the population I most work with tends to be queer, trans, gender nonconforming, Black, Indigenous people of color. Yeah, that's who I serve. That's who I love. And I'm very happy to be here today. Thank you.
Thank you and welcome on. Lynetta. You're on mute.
Hello, everyone. My name is Lynetta West, and I'm from Birmingham, Alabama. I work for Connection Health. First, I'm a community health worker, but I operate as the program manager for Connection Health. What we do, we hire, train, and employ community health workers. One of our main contracts that deal with birthing mothers is through Jefferson County Department of Health. It is called From Day One. We interact with mothers who are assigned community health workers who work with them throughout their pregnancy, and they will stay with baby until baby is 1 year of age. And this program was established to help prevent infant mortality. Alabama had one of the highest rates. So we are grateful for this program and the community health workers that we staff. Thank you. It's an honor to be here.
Thank you, Lynetta.
Thank you.
Joanne.
Hi, this is Joanne Allen from Chicago, Illinois. I am an international board certified lactation consultant, a registered nurse with a specialty in maternal and neonatal nursing. And I call myself a refired nurse because I actually retired during the pandemic. And now I am working as a program coordinator for Howard Brown Health. And I'm an active member of the Chicago Region Breastfeeding Task Force. And I am so happy to be here because we know how COVID impacted our families. And I experienced it from the hospital to the community. So thank you all for being here to support our families.
Thank you, Joanne. Julia.
Hello, my name is Julia Marinas. I'm a semi-retired registered nurse with a background in maternal child health, public health, and currently still working in programs supporting doula services and children and youth in care that are under the age of 6. I also represent our area on the Illinois Home Visiting Task Force, and am part of Illinois Public Health Nurse Administrators Group. Thank you.
Welcome, Julia. Now the gang's all here. Let's kick off our discussion. I'm so excited to talk to everyone it's afternoon where I am. So our first question, and Lynetta and Kayayo, I'm gonna let you all take this question. Birthing people's stories reveal that the COVID-19 pandemic has heightened the number of stressors birthing people are experiencing, including job loss, pregnancy-related anxiety and stress, intimate partner violence, we've seen that a lot, and racism and postpartum depression. How has the COVID-19 pandemic impacted the mental psychosocial, and emotional health of birthing people that you serve? And either of you can take it first.
Okay, I'll go first. Thank you so much. Everything that you stated, we've experienced it with our clients. We already from the start, some clients that we get, they already have mental issues or just some type of emotional issues. And we're there as community health workers to help navigate them through the project. One of the things that we found, a lot of clients during this time got off of their medication that they needed, not taking meds. There were a delay in appointments, especially in mental health, just trying to get that client in. So we've had to network to try and get clients in to get the help that they needed. If it was a severe case, we would direct them to crisis center or either to the emergency room. One of the other things we found, a lot of our parents had other children in the household. There were stressful situations because our community health worker were checking on other children in the household, making sure we switched over to virtual learning, making sure those other students were able to continue on with their education. And we found that it was just very stressful. And the good thing about it with community health worker, they were able to have someone to help them navigate through, someone to be able to counsel them as a lay person. Those were some of the challenges that we found during this period of time.
The amount of fear, anxiety, loneliness, and depression really increased among the clients that I worked with, especially my doula clients. It was the fear that they would have to birth alone. It was the fear of birthing without their doula. It was also the fear of like getting COVID from one of the nurses. Trying to support folks through those fears, right? And then postpartum was probably equally challenging as birth and prenatal, because we, want the community to support the new families, and we want family members, intergenerations to support, the young ones coming up. But folks couldn't have their mom fly in to work to support them, or their sister-in-law to support them. And so the amount of support that they would have usually gotten from outside help, family members and friends, was not available to them, which for some folks increased their level of depression. And doulas did the best that we could to support them, but we're not professionals in that way. And so there were definitely lots of referrals out to folks that can support with mental health experiences. And there were waiting lists and long waits on the phone. And sometimes some clients were just like, forget it, nobody's going to pick up, nobody's going to respond, I'm just going to be okay. So yes, I had some clients that got care, and then some clients that were not able to get care and were frustrated with the way the system was working in this way.
Thank you both for those, lifting those things up. And not the great thing, but what we see there is that these are the same issues, systemic issues that we even saw before. And so they were, the pandemic really exacerbated and kind of, I like to say, rang the alarm on the things that we've been ringing the alarm on for years anyway. And so, it shed more light, and I really appreciate the work that you all have done and the time that you took even during this pandemic to address those. So Deborah, I'll pass it off to you. You're up next.
Thank you so much for those insightful feedback. Doulas and CHWs, they rock. We're so thankful for you. So my next question is actually for Tamara and Joanne. So an interesting finding that came out of our study is that birthing people, specifically BIPOC folks, described experiencing a heightened exposure to racism and discrimination while navigating maternity care. Yet, they felt that due to being COVID positive, their providers saw them as human for the first time, providing more compassionate care. So, what has been your experiences as a nurse midwife and a lactation consultant caring for BIPOC people during the pandemic? And you can take the questions. Either of you can go first.
I'll start. So I think, again, what's most striking is the creation of this new intersection of, what have been these historically horrific birth outcomes for BIPOC folks. Many of us, we already touched on some of the statistics that Black birthing people are 3 to 4 times more likely to die of pregnancy-related causes. For Native Americans, it's 2 to 3 times more likely than our non-Hispanic white counterparts. And then you combine that with COVID, which is also disproportionately targeting us. Here in New Mexico, it's really devastated Native communities. At one point in 2020, there were 57% of all COVID cases and 50% of all COVID deaths were among Native Americans, who make up 9% of the population. So, it's just a really surreal landscape that this is going on. And then we see all of these complications that are associated with COVID infections. We're seeing increases in preterm labor and postpartum hemorrhage, preeclampsia, pregnancy loss. So it's really combining with the already existing inequities in healthcare. Here in New Mexico, we have seen a successful vaccination effort, fairly successful. We have about, last I looked, like 66% having completed their vaccinations, with the highest among our Native American folks, but the lowest is among our African Americans in New Mexico. And then another compounding factor that has happened here is that, particularly for Native Americans, they have suffered some of the worst rates and outcomes, but then they've also been targeted for the fact that their communities have been so devastated. So there was a ProPublica article that people may be familiar with. There was a local hospital here in Albuquerque that in 2020, early in the pandemic, started targeting, profiling folks that they believed to be Native American based on their zip code or their last name or even appearance. And they were actually separating moms and their babies prior to even testing, just separating families, like the most important time for attachment. And so, the pandemic has started with just such fear amongst people here. And just as it's gone on, I think we're exhausted. I think communities are pretty traumatized, so are healthcare workers. I think another thing that we see that's really difficult is when we do care for our patients, we have this disconnect where we're either doing these virtual visits, which are much fewer now, but we still do them. And then when we're in person, we have these physical barriers of PPE. And so it's just so much harder to support our families, and so yeah, there's a lot of ways that it's affected our birthing people.
Definitely, Tamara, I agree with you 100%. And I'm going to share my perspective because I've witnessed this structural racism and bias for over 40 years. And I want to thank you youngers for calling it out, because back in the day, you couldn't just come up and say there was racism. People looked at you like you were crazy. So thank you for sharing those truths. Thank you so much. And my experience initially was in the hospital. And for me, it was scary. It was traumatic because I saw families separated, not just because of the COVID positivity, but because they didn't want to come to the hospital. So sometimes the families didn't want to come because they were afraid of being exposed. In our institution, when COVID first hit, we were taking care of people who were sick. I had taken care of 2 people who were so sick, they couldn't even take care of their babies. And this is before we had a diagnosis, but we knew it was something. By the time we recognized that it was COVID and these mothers were sick, what I can tell you is that oftentimes the parents were afraid to not only be there, but they wanted to get out quick. So they were being discharged sometimes within 24 hours. Oftentimes they weren't being prepared. But luckily, in the institution I initially worked in, the medical director recognized the importance of families staying together. So even if a mother was COVID positive, the baby could stay in the room, but be kept at distance unless she was feeding. Mother had to wear a mask, and the other provider had to be in the room to take care of the baby, needed to wear a mask. And during that time, it overwhelmed me personally because I had a new granddaughter, my first granddaughter. So I made the decision actually to retire. So I left the hospital as a nurse after working for 40 years. I danced my way out of there. But what I danced my way into was, at that time, I was working with the Chicago Region Breastfeeding Task Force to help increase breastfeeding in the community. We were also given a grant by Rose, Reaching Our Sister Everywhere. So I actually helped do telehealth, phone calls. I worked with a really dynamic group of women, birth, breastfeeding in color. We supported mothers by talking on the phone. We got a Zoom link. We did whatever we could. I worked with peer counselors, doulas, who I wasn't going into the home, but oftentimes they agreed to do it. Many other mothers were so happy to get the resources. But one thing I can say, sometimes they wonder, why are you giving me this for free? So there was some mistrust of us as well. And I did that for a while. And just recently, in September 2021, I reclaimed my role as a nurse and went back out into my community of Inglewood, where I was born and raised. And I became a program coordinator at Howard Brown Health Center, where I'm working with another dynamic group of healthcare providers who know the importance of providing services, not only to the BIPOC community, but the LGBTQ community. And I'm also helping our team initiate a centering program, because we know in Inglewood, we have one of the highest infant and maternal mortality rates, but we do not have a birthing hospital. During COVID, several hospitals closed their labor and delivery units. Several hospitals were even attempting to close. So the resources weren't there for our mother. And I just want to say that what's important to me is groups like this coming together to shine the light and identify the needs of our community so we can help provide that for them. So thank you all for being here.
Man, that is so powerful. Thank you so much, Tamara and Joanne. My goodness, as you mentioned, a lot of these issues that we were talking about even before the pandemic had just been compounded. And I really salute the work that you're doing in your communities, which really centers around community-centered care, community-based care, how we show up, how we lean in, how we listen, and how we are making sure that they're not getting lost in all this shuffle. Because Tamara, you mentioned a very critical point, which a lot of when we talk about data, a lot of individuals, even within public health and clinical care, is like don't really understand the impact of the pandemic on our population. So thank you so much for bringing that to the forefront. Joanne, I'm so incredibly happy and proud of the work that you're doing and that you're still here. And, mentioning, as an elder, when I use the elder, not just for your age, we talk about this, but, being able to bring us, take us to when you were growing up and what that meant, right? And being here in this space, being able to name and shame in so many ways is really incredible. So thank you so much. So I'm going to move to our next question, which is for Kahayo and Tamara again. And my question it's about the challenges that birthing people in our studies that they've identified. So the recurrent challenge that has been identified by our birth people in our study was a restriction of support persons to attend in-person appointments and birth. With the Omicron variant, how has this restriction changed among healthcare providers and institutions in your areas? And how have these restrictions impacted the birthing people that you serve?
This is a very big question and one that I revisit every week because things can change week by week, day by day. I forgot to mention in my intro that I am a member of the Roots of Labor Birth Collective. And one of the biggest impacts on the birthing people has been the reduction or just not even having doula support for incarcerated pregnant and birthing people and postpartum people. And so we already know that we don't treat incarcerated folks with dignity and respect, right? And so then they're going to have a baby and be alone at the hospital when birth in itself is already something scary that no one wants to do by themselves, right? So that's the restrictions, like that group, I can't highlight it enough. It makes me really emotional to think about incarcerated folks not getting support, right? And not even getting postpartum support after they birth their child that may be going into a system, right? That's a whole nother conversation. The other thing that I have been experiencing with clients is, right now the hospitals are like, yes, you can have your doula, but on two things. Well, now with the new variant, it's like your doula has to be vaccinated, and show their proof. Well, we all know how Black folks feel about the medical system, right? And so there are lots of folks who are choosing not to get vaccinated, and that's everybody's choice for their own bodies, right? And so if you're not vaccinated, then you can show a negative COVID test within 24 to 48 hours. But we all know that with birth, we don't ever know when that's going to happen. So that's kind of impossible in my way of thinking. The other group, so I also work with folks that are birthing at home, and sometimes folks birthing at home need to transfer to the hospital. Under normal conditions, their doula can come, their midwife can come, whoever was there supporting them at home usually can go to the hospital with them. But that is not the case right now. It's still the one support person and then the extra support person. So, then that client has to choose, do I ask my midwife to come or do I have my doula come? And you're in labor and you have to make that choice. Being creative, I've just been on the phone a lot more and had a lot more screen time with clients. I've been on Skype, I've been on FaceTime. And that was really in the beginning. Now it's a little bit easier, although still not having in-person prenatals visits, which is how do you get to know someone and connect with someone while they're pregnant safely to be able to support them in developing what they desire for their birth, right? Yeah, a lot of us are burnt out. Honestly, we are burnt out, but we keep going. We keep going for our people. Thank you.
Thank you so much for sharing that. Tamara, I'm going to let you go before I make it.
Yeah, thank you. Yeah, so I can talk a little bit about how it's been how our hospital policies have affected folks, and then also for our volunteer doula program. So the most dramatic changes definitely came with the beginning of the pandemic. Originally, in the beginning, we were not able to have support people come to clinic. And so our birthing people were coming alone. Which was, really difficult on families, on partners. I think somebody else before mentioned, the issue of bonding, of, not being able to hear those first heart tones with mom, and that can be really challenging. And then in labor and delivery, originally we're having one visitor, one support person with a patient. And then we also would do a lot of groups. So prior to the pandemic, we offered a centering prenatal care group. We also offer something called Roses, which is a program that is a group for postpartum depression prevention. And then those had to go virtual and still are. We're not doing any groups in person, which I am just a really strong believer in the power of groups and the power of sitting in a circle. And it's just such a loss to not be able to do it in that way. In the beginning, we did have folks that were, still interested in joining us virtually, but I think we're all having a bit of Zoom fatigue. And so those groups are not as robust anymore. And then for our birth companion program, it was completely put on hold. It in part is supported by our volunteer services in the hospital, and they just stopped allowing any volunteers. So our program then tried to support patients a bit virtually, which, it's just not ideal in any way. And then we also had volunteers who would just individually offer their support, but not, under the umbrella of our volunteer organization. And now that our birth companions are back in the hospital, they are considered part of the staff, so they don't count as one of the support people. And families can have 2 support people. Unfortunately, the current policy is that doulas outside of the volunteers are considered one of the support people, which is really challenging, particularly for a lot of birthing people. Then they come down to the decision of their, usually their partner or their mom, which is, a really hard decision to make. So that's something that we're still, needing to work on. Another thing is just the lack of staff. We're just so overwhelmed, or we have, lack of staff, lack of available beds. Just this last week, we've had a military medical deployment of personnel to come help with staffing because we're so understaffed. So, people are waiting really long times to get rooms. It's just still really challenging in that way. It's like the challenges have changed. And I feel like I'm seeing people who are now having their second baby during the pandemic. And you can see how the trauma from their isolation and the fear from early pandemic is still affecting them. And, I imagine that's going to continue to affect people for a long time. I recently cared for somebody who was having their third baby. Their first baby, they had a C-section, and then their second baby, they really wanted to attempt a vaginal birth after cesarean, but it was the very beginning of the pandemic, and they had to choose between one person, and they felt like it wasn't enough support for them to effectively have a vaginal birth. So they felt really like cornered into having a repeat C-section, and did go down that route, and then chose just recently with their third baby to again attempt a vaginal birth after cesarean. But it was just really apparent how much trauma was with them from that last experience. And it was still really fresh and really frustrating for them. And I just imagine those sort of original and ongoing traumas are going to be present for a really long time.
Thank you so much for sharing that. In the interest of time, I have a follow-up question for both of you. And it's about the rate of home birth. So Has it increased during this period for both of you in your practice?
Yes, it's definitely increased. It's definitely increased a lot here in Albuquerque. We have a really vibrant home birth community. So it's always been, there's always been a lot of folks who chose home birth. But I definitely saw it increase in the beginning, and home birth midwives that I know were really overwhelmed with the amount of people that were interested. It was also an interesting transition because, you know, people who choose home birth typically have a really strong interest in that type of birth. And suddenly some people were choosing it because they were fearful. They were fearful of the hospital. And that's also a really hard way to choose you should choose your birth setting out of what makes you feel safe, not out of what you're afraid of. And so I was really, really unfortunate to see people feeling like they had to make that decision out of fear. But yeah, there's definitely been a lot more home birth.
How about you, Caio?
Yeah, there's definitely been a lot more in Oakland as well. And like I said earlier, there's not a lot of Black midwives. And so a lot of BIPOC folks are seeking to birth outside of the hospital. And some of the BIPOC midwives are taking on more clients than they usually do. And yeah, 2020 was one of the busiest years that I've ever had. And, you know, it was nice to welcome people to birthing at home and support them through those fears. And it also is not always sustainable for everyone. And so making access and support available for home birth midwives would actually be really helpful in terms of them sustaining and not leaving the profession.
Thank you so much. This brings me to, when you talk about incarcerated people and the violation of their human rights, this is really what it boils down to, as well as, not having the chance to make informed decisions about where they want to give birth. So that these are really critical, critical questions and, thoughts and feedback. So I'm going to, in the interest of time, I'm going to invite Julia and Lynetta to this next question. And so within our studies, birthing people have not been having the adequate tools to engage in telehealth appointments. And this has often left them feeling like their provider was unable to fully assess the progress of their pregnancies. What are some of the barriers that your community has experienced while engaging in telehealth appointments? And Julia, you can start.
Well, at the beginning of the outbreak, barriers in our community included determining what types of meeting formats met HIPAA standards. We had some people talking about things that they shouldn't have been out on Facebook, and we really had to corral all that together. And then the next thing was the equipment that was needed to complete virtual visits or telehealth visits, as well as just a general discomfort by both families and the medical community to change to telehealth. In fact, when COVID parameters went into place, many families just missed prenatal visits, or they may have presented in the ER as needed, but there was no good option that was quickly available for us in this rural community. I will say that our WIC and case management services were able to quickly pivot and do telehealth phone calls and use that to complete WIC appointments. And then we set up a drive-up outdoor system to pick up coupons. And then the other thing that WIC did was to put a little more emphasis on completing nutrition education sessions online and getting certificates, and then being able to come in and just pick up your coupons that way. So those are some of the things that they did. The home visiting kind of followed a little bit and lagged behind them, and their goals were to get Zoom in place. And then that involved training of the staff and its use. It's also, I think we had to do some upgrades on computer systems. And we would just continue to offer families any kind of combination of supported visits that worked for them. We would do a lot of dropping off materials at houses and homes, or set up things and send them as email attachments. But in general, families' lives were just turned really upside down. And no one day looked the same as the other, and no one answer was the same solution for every family. Work, school, daycare, shopping, everything came to a halt and changed dramatically. We all know that. And that in turn caused an increase in the stress and mental health and social emotional dysregulation that we started to see by all the family members. And then I guess the icing on the cake is to add to that the deluge of information families were getting and providers were getting. The information, the changing information, the misinformation. Families were really being pushed to the edge and left scrambling to find resources as their situations changed, whether it was with pregnancy, newborn, access to medical care, family planning, etc. So that's what we saw in our community.
Okay, thank you, Julia. One of the things that we dealt with clients having to go to telehealth. In the clients that we dealt with, one of the things, having that phone available, some of our clients ran into phones may be disconnected when it was time for their appointment. There was no way to call in. One other big issue that we found in our Spanish-speaking clients, making sure that there was an interpreter to be able to help them with that phone call. We ran into quite a bit of problems here in Alabama dealing with those type clients. One of the things with having a community health worker with our program that we had, that client was able to connect with their community health worker and talk with them prior to the appointment. If they were able to get in contact with them, that community health worker helped them to learn how to ask questions, to know and answer questions about their pregnancy. They encourage them to write the questions down so that when you get into that appointment, you're just, you know what to ask. They taught them about numbers. If we had a mom whose blood pressure might have been up, write that number down. So when you talk with your community health worker, you will know what that number is. If they're asking questions, then they can't remember. So that was one thing. We just tried to educate them. We had to resort to Google FaceTime. An option was also made to try and help that client not feel so lonely when they went to the telehealth services. That community health worker could go on Google FaceTime if that client chose to have them right there to hear what was going on with the appointment. Another thing we ran into, when it was time for the client to have that initial visit, she was able to go in to get the diagnosis of pregnancy. She was able to go into the health department. They were able to have that contact when it was time for genetic testing, other testing. They were able to make contact, but that community health worker stayed as a layer in between, a liaison to help bridge that gap for them, because they felt so isolated, not being able to have someone with them when they went to that appointment. But the main thing, just trying to keep them on schedule, making sure that they do find a way, even if their phone was disconnected, or making sure that number was available, that gave the correct number, and just making sure they were able to ask the correct questions that they needed and to understand what barriers that they needed to work with. So it's very, very difficult when they switch to telehealth, because that way, before that, they were able to have that community health worker with them on that visit. They can go into the exam room with them if needed, but it made it so isolated, and we had to heavily depend on information that client brought back to us. Mm-hmm. So that was the thing, and just educating them, making sure they asked the questions to be able to bring that information back to us. One other thing we found with having the community health worker model, once they communicated information, if there was an emergency, we were able to contact our person, our RN at the health department so that they can get the medical help that they needed, or they can go in and talk with other doctors to get that immediate help. But this has isolated so many of our clients where they just felt like they were in it alone and just felt like they had to accept what the doctor told them. At that particular time with the telehealth appointments, you know, clients are being asked, we want to go ahead and schedule an induction. We face that. And, you know, we're talking with the clients, why are you having an induction? Well, I don't know, the doctor just said, and I'm sure a lot of them went in and complained, I'm just tired. And I know that it was scheduled a lot of times on occasion so that they can go ahead and do COVID testing while that person is in the hospital. But these barriers as far as switching to telehealth, we just had to just really encourage our clients to educate them, educate, know what your numbers are, write down, have that phone available so your community health workers right there if you needed her to hear what was going on with you. But I'm thankful that we had community health workers available to hold their hands and encourage them, make sure you make that appointment, don't miss it. So
thank you so much, Lynetta.
They had help
Thank you
available.
so much.
Yeah.
And I know we're going to have more time during the Q&A to expand a lot of all these discussions, but I want to get to a very critical question on breastfeeding, and I leave it to you, Dr. Burse.
Okay, yeah, we've talked a lot about the birthing experience during COVID. So we do want to highlight, and I know in the interest of time, a little bit about breast and chest feeding. And Joanne, we'll direct this one to you in the interest of time so that we can get to our solutions quickly. So birthing people have shared not having access to lactation consultants during pregnancy and birth, which often results in them experiencing challenges during breast and chest feeding. Can you describe any challenges that you've had to navigate to provide lactation education and support to the birthing people that you serve during the pandemic?
Yes, and definitely. But one thing I always try and find something good. Some of the mothers who experienced COVID during this time actually were able to breastfeed more because they didn't have as many. So there's always another side. So for me, there were a lot of challenges. I work in Inglewood, St. Bernard Hospital, which was the only birthing hospital in Inglewood, and they had a lactation consultant close their OB during that time. Another birthing hospital, two of them actually closed. So they didn't have that support. They had to go places they weren't necessarily used to going. A lot of challenges happened throughout because, for example, I wasn't able to go into the home, so I had to depend on other peer counselors and lactation consultants to come in. And as a part of a group, we actually wrote an article entitled Structural Racism and Barriers to Breastfeeding on Chicago's South Side, and it's in the Academy of Breastfeeding Medicine from last year because we recognized the problem. So a lot of what we did was look at supporting each other. We worked with Birth and Breastfeeding in Color, the Illinois State Physical Activity and Nutrition Program provided grants. We worked together as a team. The Chicago Region Breastfeeding Task Force actually held baby showers. So a lot of the challenges meant that we couldn't go into the homes. So we tried to get people to come to us. We went into the community. The challenges were there's not enough BIPOC people who could be there to support the other family. So you want somebody to help you that looks like you. So we actually, me personally, help support training so we could replicate lactation. There's not enough lactation consultants of color. But I think that's one of the things that came out of this pandemic was we realized that they were not enough and monies came down to help provide that. So I want to thank all of you and thank CERISH for the work they are doing to make sure that the BIPOC community is included and that we get the resources that we need.
Thank you, Joanne, and thank you, everyone. We're running up on time. This has been such an amazing discussion, and so we want to get to some solutions very, very briefly. I know we want to get to some questions and answers. So just everyone, if you could give just one solution, very brief, well, let's just look at it like this. So this multi-level solution, birthing people have identified multi-level solutions to address the challenges they experience navigating maternity care. And so what is one solution that your organization has implemented? And in any resources, if you have an abundance of resources, you can drop them in the chat for us, but just one word solution if possible. We'll start with Tamara because I'm seeing you right here on my screen.
I think just really being flexible and really centering your families. So things like, doing visits in the car, going out, into the parking lot of the clinic so that family can be there, or, whatever is really most important to the families that we care for, trying to be creative and incorporate those things for them.
Thank you. Flexibility. Kaio?
Being compassionate, being compassionate and sensitive to the experience that folks are having and supporting them in those difficult moments.
Thank you. Compassionate. Julia?
I think in our community, I would say it would be more community collaboration. And an example of that would be once the school had worked with teenagers to get them laptops and things to be able to access schoolwork, we worked with the school to let them allow the teen moms that were pregnant to use those to access prenatal appointments and doula visits and home visits that way virtually.
Thank you, Julia. Community collaboration. Joanne?
I was going to say collaboration, but I'll say education. We have to educate each other and replicate lactation consultants and counselors in our community. Education.
Education. Thank you, Joanne. Lynetta?
Our main thing is networking with community partners. That's one of the main things that we've learned, teaching our clients about resources that are available and at hand, and meeting our clients where they are.
Thank you so much. This has been so good. You all have shared your expertise. It's been amazing. And it's just been invaluable to have everyone on the screen. And it's been a good time for me too, in the middle of my day. So we're going to get to some questions and I'll turn it back over now.
Fantastic. Thank you everyone for your amazing feedback and just sharing with us your wisdom. I'm gonna start getting into some of the questions. If you have a question you want to ask live, please raise your hand. But I'll start with the first question here. And I guess anyone who wants to jump in, please do. This question is from A. I am also wondering what hospital recommendation would you make or have you made to support our community when in labor?
I would support allowing more than one visitor being present in the room. Yeah, that's hands down. If there's a partner or family member, and if they have a doula, allowing both people to be present for the duration of the time that they're laboring and birthing.
And I would just add on to that to say that in our community, we worked with one hospital so that they begin to recognize our doulas as hospital support staff. So when they were doing the count in the room, the doula did not count as the one visitor or the one other person.
Thank you. Our next question is from Azalea from Black Infant Health. what is a piece of advice you would give to healthcare workers who provide direct service to vulnerable Black and Brown women as it relates to COVID-19?
I think just around care in general, but especially during COVID-19, that it's really important to feel empowered to pick your healthcare, your provider team, and that you feel comfortable with them and trust them, and that you feel like there's transparency, and that you can have your questions answered. I think sometimes people feel like they show up at an appointment and they're given a provider, and that's, who's going to care for them. And it's important that people feel like they can make that decision. You can, interview people and find the right team for you.
So much, Tamara. Our next question is from Alexis. Alexis writes, I work with young mothers who are in high school or getting their GED. We have had several clients who have tested positive for COVID-19 or shared fears and hesitations regarding the pandemic or vaccine. How do you suggest we support our young parents during this time?
I can answer part of that. We deal with a clientele of mothers. A good number of the mothers have not completed their high school diploma. We work with, again, back to community resources, working with people who will work with mothers. There are programs out there. You will look at community-based programs that will help your mom get their GED. Keep in touch with them virtually and just encourage them to go ahead and get the additional education that they need. That's one of the things that we do with our program.
And I would add to just say to let them drive the vehicle of that, of feeling safe. Whatever it is that makes them feel safe and be in that spot with them where they are and at any given time. And then provide information and education to see if maybe at some point where they feel safe or how they feel safe may shift.
Great, thank you all. This is a cool question. This is from Shadima. I hope I'm saying your name right. How do you all suggest drawing together a village or team for pregnant and birthing people? Joanne, I saw you react, so I don't know if you wanted to.
Well, I believe in collaboration, and I think we have to lean on each other. So if my specialty is lactation and there's a patient who needs a doula, then I'm going to call my friend the doula. Being involved in organizations, for example, I'm very pro the task force. I'm a member of the Chicago Region Breastfeeding Task Force. I'm a member of the Illinois State Breastfeeding Task Force. So within those groups, I'll call on someone to help me. So I believe it's important that you recognize your specialty and you collaborate and work as a team.
I'd like to say something to that. Just what you said, Joanne. One of the things that we saw during this pandemic, a lower rate of breastfeeding. And I knew that you were on my team, Joanne. So what we did, we called Joanne in, and she did a teaching session for our community health workers. She has also been a part of our safety showers that we do quarterly in the with our moms in their third trimester. She has come in and she's demonstrated how important it is for breastfeeding, the benefits of it. She has done an amazing job in helping our mothers. So just as you said, pulling from those networks that you know and asking them to come in and help you. And Joanne, we want to thank you we still have future sessions that we've scheduled with Joanne. So with this village right here, we have pulled in all areas and we have come together and we help each other. Thank you, Ms. Deborah, and all of you. We can call on you and just help collaborate in whatever needs that we have.
Anyone else want to add to that? Yeah, I think that was beautiful. I also have a question about resources. So this question is from Elle. They're asking about resources for new doulas to connect with community in need and or other working professionals to help integrate into the community. This person is in the SFA area and Las Vegas, but I think any sort of resources would be helpful.
In the East Bay, we have the Roots of Labor Birth Collective, and it's for doulas and birth workers of color. So only BIPOC folks. I'm not sure if you're BIPOC or not, but if you go to the Roots of Labor website, there is some ways that you can connect with the community. One of the ways is Tuesday nights, they have what's called a doula circle. And that's where all the birth workers hop on like a Zoom and we'll kind of talk about what's going on and share some skills and kind of do like some collaboration and working together. Yeah, that's what I've got for the East Bay.
Awesome. I know we are running up on 2 minutes left in this session. I think that we might start wrapping up. I see that the chat is active. I see there's more questions. I apologize if we did not get to your question. Is there any question that the panelists see in the Q&A that they want to answer? Just want to give that opportunity. If not, go ahead. No, I thought I heard something. Okay. If not, I just want to thank everyone for being here today. And I want to give a chance for Dr. Brittany Chambers and Helen to share any last words.
I would just like to extend gratitude to the birthing people who are involved in this study. We were able to recruit 35 and follow 35 to their postpartum periods, to our amazing panelists. You know, all of our panelists are either CAC members of CERISH or an organization working with CERISH. And this is us. This is us. This is CERISH. And we hope that this information inspired you all to take action, to find out about these wonderful panelist organizations, to see how you can be involved and support this work.
I agree and echo everything that Brittany has said. Everyone has been so lovely to work with and so powerful. Thank you all as a community, as a village, as a tribe, for being here and showing up in this space for all of us today and for all of the birthing people. And I also want to say to Brittany, she's been such a pleasure to work with, and I feel like she doesn't always get the credit she deserves, but I just want to shout out to Brittany for your vision, for your work, and it's always been a pleasure to work with you.
She's just a girl and she's on fire.
Love you all.
Thank you all.
So much. Like hugs
Thank
to
you.
the village.
Take care.